Oh, sorry.
What is that? Yeah, that's Why is it doing that? Why is it doing that?
As we get started, I want to welcome everyone to the surgical illustration presentations for the class of 2020. Since August, our students have been observing and sketching procedures in the operating rooms here at Hopkins. So we give sincere thanks to the surgeons and the trainees and the OR staff who've made these experiences one of the strengths of our graduate program. For their surgical illustration course, each student sketches all of the steps to 3 operative procedures and then completes final artwork for one of the steps of each procedure. The audience for these pieces is surgeons and trainees. The students also redesign and illustrate one of the procedures for a lay audience. We refer to this as the patient education piece, and you'll see examples of some of these images projected today. And you can see all the surgical illustrations they completed for the course, including the procedure they're not presenting on the podium out in the reception area. So today each student will present 2 assignments. First they'll describe the procedure showing their full set of pencil sketches. Then they'll present the figures in a layout for a journal, book, or a slide presentation. And finally the student will show the finished artwork and invite comments on those images. So when we review and critique artwork in the department, in addition to good draftsmanship, we consider if the student effectively conveys the information clearly and accurately, and we ask what is the main message of the illustration. We also consider the uniqueness of the pictorial solution if the student is showing something that a camera couldn't capture. We appreciate you joining us today. We look forward to seeing some great images. And I will invite our first student, Kellen Sanders, to the podium.
Thank you, Corey, for that introduction and for all of your help throughout this course. The first procedure I will be presenting is a middle cerebral artery brain aneurysm clipping. Just kidding, maybe I'm not. I will take you through a series of pencil sketches of this procedure. The top left image shows the dashed line, which is the incision that the surgeons make. In figure 1, the scalp is reflected. Rainy clips are placed around the incision for hemostasis, and then the temporalis muscle is incised and reflected. Figure 2 depicts a frontospinotemporal craniotomy with 5 burr holes into the cranium, which you can see here. In figure 3, a jiggly saw is used to connect the burr holes. The arrows indicate the motion used to saw the cranium from interior to exterior. The bone flap is then removed. In figure 4, the dura is incised to expose the sylvian fissure, which can be seen slightly right under the word dura. Following the sylvian vein, the arachnoid matter is incised. The inset on the right shows the microscope view of the arachnoid matter. You can see wherever my pointer is at, the sylvian vein, which the scissors are following. Vessels and arachnoid matter are dissected from brain tissue to expose the middle cerebral artery and aneurysm. 7 is a coronal view of the surgical exposure, while 8 provides a microscope view of the completed dissection, with the middle cerebral artery and associated aneurysm. Here you can see on the right image, sorry, wherever the pointer is at. Okay, here you can see the internal carotid artery, and then the branching middle cerebral artery. This portion is the first segment of the MCA, and these are all the second segments. And here is the aneurysm. In figure 9, a temporary clip has been placed on the first segment of the MCA to reduce blood flow to the aneurysm. Then, the aneurysm is permanently clipped across the neck, blocking blood flow to the extremely thin dome of the aneurysm. In figure 10, the temporary clip on the first segment of the MCA has been removed, and the permanent clip has deflated the aneurysm. In figure 11, the dural flap is repositioned and sutured. In figure 12, the bone flap is replaced and secured with 4 burr hole covers in small screws. A small mesh is secured over the 5th burr hole, seen here. The temporalis muscle is repositioned and sutured to the mesh, as well as the fascia and muscle previously left on the cranium, which is here. In figure 14, the scalp is closed in 2 layers, first using an interrupted intradermal suture, followed by a running suture for skin closure. For my final illustration, I chose a journal cover format. This full color illustration depicts the overview of the exposure in the coronal section on the left. The right 2 images depict placement of the permanent clip and the before and after removal of the temporary clip. I now open the floor for comments and critique.
Compliment you on your very detailed series of operating sketches. You've taken on quite a difficult surgery, and you navigated through the surgery easily for us to understand.
Thank you. Okay, if there are no other comments, I will continue. The second procedure I will be presenting is a sigmoid colectomy. The patient underwent the removal of their sigmoid colon to treat diverticulitis, which commonly occurs in the sigmoid colon. In figure 1, the patient is placed in extended lithotomy Trendelenburg position. This position lowers the head, shifting the abdominal organs out of the pelvis to provide a better view of the sigmoid colon and rectum. In figure 2, the abdominal cavity is accessed using 3 5mm trocars and one 10mm optic trocar, which is seen in black. The optic trocar is where the camera is inserted, through which we are viewing the operative steps. The darker gray portion on this image shows where the colon will be removed. The top inset up here shows the angle of the laparoscopic camera for the related steps. This convention is used throughout the presentation. In figure 3, the retrosigmoid junction is elevated, providing exposure to the mesocolon and retroperitoneum. The surgeon identifies the ureter and common left iliac artery before making an incision, which is seen here. In figure 4, the sigmoid and descending colon are dissected bluntly, posteriorly up to the splenic flexure to release and identify the inferior mesenteric artery and vein. During this mobilization, the descending colon remains suspended along the white line of Tolt to provide retraction and maintain exposure. In figure 5, the inferior mesenteric artery is being ligated, afterwards the vein is ligated. The inset in the top shows where the IMA will be ligated and where the IMV will be ligated. Next, the descending colon is released from the body wall along the white line of Tolt. In 6A, the ligature incises the thin attachments which suspend the descending colon. 6B depicts blunt dissection parallel to the descending colon, proximally towards the splenic flexure. So the surgeon will head this direction. In figure 7, the greater omentum is dissected from the colon, but left attached to the greater curvature of the stomach. In figure 8, the descending colon is elevated, further dissected, and smaller vessels are ligated as needed to prepare for division. This concludes the laparoscopic portion of this procedure. In figure 9, a fan and steel incision is made in the lower abdomen, extending from the suprapubic port laterally in both directions, as shown in this top left image. In figure 10, a wound retractor is inserted and positioned to expose the mobilized descending and sigmoid colon. In the top left inset, 11A depicts the proximal line of division, which is done outside of the body, seen here. This operative step is shown in the sketch on the right. The distal line of the resection at the retrosigmoid junction is shown in 11B and performed by inserting a contour stapler through the wound retractor. The specimen is then removed from the body. In figure 12A, the staple line on the proximal colon is removed. Next, an anvil for a circular stapler is inserted through the teniae coli and then secured with a purse string. This step prepares the proximal colon for anastomosis. The surgeon then inserts the circular stapler into the rectum and mates the anvil neck with the circular stapler spike. This stapler creates an anastomosis between the proximal colon and the rectum to reestablish continuity of the lower GI tract. I chose a slide layout for this piece. In this figure, the inferior mesenteric artery is being ligated. Again, the inset in the top left shows where the vessels will be ligated, IMA and IMB. I chose to render in tone with focal color on the artery and vein. The purpose of this piece is to be used as an educational resource for residents. I now open the floor for comments and critiques.
I just wanted to compliment your treatment of the mesentery. It's, I know it was a real challenge to figure out a way to pick out the transparency and also having it be pulled up gently to expose exactly where to put the needle or the inferior mesenteric artery. I think you did that really successfully. I can tell it's nested inside the mesentery, and I can see exactly what the challenge is.
Thank you. Corey?
I think your use of spot color is very effective, and I think you're clearly showing what a camera can't capture by pulling back a little bit and giving us a little bit more of a landscape, including the vision in the lower left. And I think that your convention of using the little flashlight images with the camera
No further.
We have some Facebook feedback,
Okay.
and it was really nice use of simplified representation and use of diagrammatic insets. And also for figure 10, the wound retractor, the addition of twists and lines really helps enhance the form and material.
Thank you.
That was Emily Ling.
Emily Ling.
Thank you, Emily. All right, thank you for that feedback. I will now introduce my classmate, Jenny Wang.
Thank you, Kelvin. For my first surgery, I will be presenting an open parathyroidectomy. Hyperparathyroidism is a common clinical problem when one or more of the parathyroid glands become overactive and secrete too much parathyroid hormone or PTH. This may lead to kidney stones and bone loss. In these cases, a parathyroidectomy is usually performed to remove the overactive parathyroid gland. I will now take you through a series of pencil sketches that describe the procedure. In figure 1, a 4-centimeter incision was made in the neck, 2 finger breadths above the sternal notch. This figure provides important anatomical landmarks depicting the recurrent laryngeal nerves, highlighted in yellow, and the 4 parathyroid glands on the posterior aspect of the thyroid gland, highlighted in pink. Identifying the recurrent laryngeal nerve throughout the procedure is important to avoid damage to the nerve. In figure 2, platysmal flaps were raised, and the strap musculature was divided, using electrocautery at the median radius. In figure 3, the strap musculature was then retracted laterally, exposing the thyroid gland. The right superior and inferior parathyroid are outlined with a red dotted line, indicating their posterior positions. In figure 4, the right lobe of the thyroid gland was rotated medially, and the bridging middle thyroid vein was ligated to increase surgical access. Figure 5 is an axial view which clarifies structural relationships. Here in yellow, you can see the location of the recurrent laryngeal nerve running alongside the trachea. In figure 6, the enlarged right inferior parathyroid gland was carefully dissected free, and its blood supply was tied off and ligated using a harmonic scalpel. Throughout the course of the surgery, the right recurrent laryngeal nerve is stimulated using a nerve monitoring probe, shown here. Figure 7 also shows the right inferior parathyroid gland post-removal. Blood is then drawn from the internal jugular vein or peripheral vein to check intraoperative parathyroid hormone levels. The half-life of PTH is only a few minutes, so blood is drawn every 10 minutes to monitor the levels. An appropriate fall in the PTH level indicated that the surgery was effective. The surgeon then proceeded with closure. The strap musculature, platysmal flaps, and epidermis were then sutured and closed. I chose to depict the removal of the enlarged parathyroid gland using grayscale tone with spot color in a journal format. Here are enlarged versions of steps 5 through 7 depicting the dissection and removal of a parathyroid gland. I welcome any feedback or comments.
Hi. I just want to say, great rendering, use of tone. Also, I love actual cross sections, so it's really great to see you do that for the relationships. I guess my one critique would be to, when you're walking us through the surgery, continue with that convention of keeping the recurrent laryngeal nerve in yellow and the parathyroid in pink, so you can follow along.
Thank you for the feedback.
There's a comment from Facebook. Emily Ling also mentions she really appreciates your spot color usage on a black and white background.
Thank you.
I'm sorry, could you repeat her comment?
Emily Ling mentions she really appreciates the spot color usage on a black and white background.
If there are no further comments, I'd like to move to the next surgery. For my second surgery, I will be presenting a robotic donor nephrectomy. I'll first give an overview of donor nephrectomies through my patient education piece. Currently, a large proportion of kidney transplants are performed from living donors. The living donor kidney transplant has many benefits compared to a cadaveric kidney transplant, and the increase in robotic approaches has made this procedure a less invasive option. This piece shows the incisions made during the surgery, and the functions of the donor kidney for anyone considering kidney donation. Now I'll go through pencil sketches outlining the procedure. The donor patient is positioned in the left lateral decubitus position. 4 robot ports and 1 gel port were placed on the anterior abdomen with the camera placed at port number 2. To gain access to the right kidney, the white line of Tolt connecting the colon to the retroperitoneum was dissected inferiorly, shown in figure 2A. This allows the surgeon to medially retract the colon for increased surgical access, which is shown in figure 2B. In figure 3, the gonadal vein was identified and skeletonized. The ureter was found running underneath the vein. In figure 4, the ureter was also freed along its course to ensure adequate length for the recipient. The liver was then elevated and the adrenal gland was separated from the kidney. In figure 6, perinephric fat and gerotous fascia surrounding the kidney were dissected away, leaving the kidney connected by the ureter and hilar vessels. In figure 7, the renal artery and vein were skeletonized to allow for them to be stapled safely. The robot was then undocked and the procedure was continued laparoscopically. The ureter was clipped at the level of the common iliac artery and divided. This allows for enough length for the recipient surgery. Finally, in figure 9, the renal artery and vein were stapled in that order with an endovascular TA stapling. The kidney was removed via the assistant gel port and immediately placed on ice. I chose to illustrate figures 8 and 9, the division of the ureter and hilar vessels in full color for a slide format. I welcome any feedback or comments.
Did I want to comment both on your previous surgery and on this one? I think you've done a really nice job of capturing the tissue reaction and realism in the tissues, but also kind of cleverly leaving details out so they're simplified and they're clear to understand. So you've done a very nice job of balancing realism with some simplification.
Thanks, David.
I'm piggybacking a little bit off of David's comment there, but it's not just for the final pieces, for your sketches throughout. I think any one of those sketches could easily be final pieces without any of the color or further rendering on them. They really convey a lot of the texture really well in your simple line making. You have so much tonality in your sketches. They're really beautiful. And you still, I like that you still keep that same mark making in your final piece, even though it's you clearly put more time into the finished ones. So very well done.
Thanks, Susie.
I think on your figure 8, you could go in and push the scissor a little bit further along in that step so that we can see the back blade of the scissor on your final.
Oh,
You have
yeah.
it on the sketch, but you don't have it on the final drawing. I think that would just add a little bit more information. It's a quick fix you can make for your portfolio.
Okay.
I'm going to offer the first critical comment so everyone doesn't think this is a love fest. I think your ureter is a little bit big. Did you check that, or is there a reason that you showed it? Is it? I think the size could be okay, but I think the lumen appears to be a little bit big.
It's too big.
Maybe if you would make the lumen smaller, you'd understand the rest is surrounding tissue and fat, which I think would be related.
Thank you for
I'm
that.
not sure what other people think.
Jen?
I was just going to compliment you on your choice of color and your palette overall. I think the instructional color is very clear. And I always find that when you have different reds, the artery, the kidney, it's challenging to distinguish the different structures. And I think you did a great job of choosing a harmonious palette that is also very clear what everything else.
Thank you.
I have comments from Facebook. So Sipora Thompson mentioned that the color rendering of the final kidney piece is really gorgeous.
Oh, thank you.
I'm sorry, did you say this was for a slide, or was it for?
Yeah, it's for a PowerPoint slide format.
That being said, I would say that I think your labels are just a little too small.
Duly noted. Thanks for the feedback. If there are no further comments, I'd like to introduce my classmate Morgan Summerlin to the stage.
first procedure, I illustrated a robot-assisted radical prostatectomy. I created this patient education illustration to explain this procedure to a lay audience. A radical prostatectomy is often used to treat prostate cancer. You can see in this illustration that the prostate and seminal vesicles are removed, and the urethral openings are connected. The use of robotic surgery can help precisely preserve delicate erectile nerves. I will now illustrate this procedure with a series of sketches. This figure shows the trocar port placements. There's a lateral port for an assistant, 3 robot arm ports, and a midline camera port. A Foley catheter is also placed in the patient. In this view, we are looking towards the patient's feet with the bladder retracted anteriorly. The peritoneum is incised posterior to the bladder and the rectovesical pouch, as you can see here. This exposes the seminal vesicles. In figure 3, the seminal vesicles and vas deferens are dissected, and the vas deferens are clipped and divided bilaterally. The peritoneum is then incised anterior to the bladder. Here we can see the previous posterior dissection and the rectovesical pouch. Looking deeper into the pelvis, we can see the prostate inferior to the bladder. In figure 6, the prostate is defatted by removing the prostatic anterior fat pad. In figure 7, the lateral endopelvic fascia is incised bilaterally, and in figure 8, the anterior puboprostatic ligaments are divided. In figure 9, the deep dorsal vein complex is ligated with an endovascular stapler. The resulting division is seen in figure 9a. The bladder neck is incised to expose the Foley catheter in the urethra. The catheter is then reflected anteriorly. In figure 11, the bladder neck incision is completed posteriorly. We now see the seminal vesicles, which are pulled anteriorly. In figure 12, we can see the divided urethra and the seminal vesicles pulled anteriorly. A neurovascular bundle containing erectile nerves runs laterally to the prostate, and the branches to the prostate are clipped and divided athermally. The erectile nerves are preserved in this nerve-sparing technique. In figure 13, the distal urethra is incised through the external urethral sphincter. At this point, the prostate is completely mobilized and can be removed. In figure 14, the posterior bladder neck may be sutured to improve urinary continence. An anastomosis is created to connect the urethral openings between the bladder neck and the external urethral sphincter. In figure 15, we can see the start of this anastomosis on the posterior side. And in figure 16, the anterior connection is sutured. In figure 17, the vesicourethral anastomosis is complete, and we see the tied suture at the top. An optional step to improve urinary continence is an anterior bladder neck intussusception. I chose to illustrate the nerve-sparing steps because this is a critical component of this procedure. These figures are presented in a slide format. I now welcome your comments or critique on this piece.
Really nicely done in highlighting the neurovascular bundle, which is so critical in this procedure.
Thanks.
The reaction of your tissues are spectacular. It gives me a good sense of space. And having drawn this before, I can follow your procedure. Your well done.
Tim?
This is an excellent example of spot color, but you've taken it even further by adding some rendering and highlight to the color itself. It's very, very nice.
David?
Maria, I hadn't seen the final of this, and as I was watching you go through your sketches, you have such an intentional, very nice, fluid style with your sketches. I was hoping that the last piece would do away with those, and it did. You've managed to clean things up and put accents and push the value range, but still keep some of the hand of the sketches in there, which I think is just really, really lovely.
Thank you. If there are no further comments, I will now move to the next one. For my second procedure, I illustrated an endonasal resection of a pituitary microadenoma in a patient with Cushing's disease. So figure 1 shows a sagittal view of the patient's right side with the nasal septum removed. You can see the pituitary tumor highlighted in blue, along with the sphenoid sinus and the nasal turbinates. The procedure begins with the removal of the middle turbinate along the incision line. Figure 1A shows the endoscopic view of the turbinectomy. The anterior face of the sphenoid sinus is entered lateral to the natural ostium, and the posterior nasal septum is removed to provide a greater access to the sinus. Figure 3 shows the endoscopic view of the posterior nasal septum being removed with a drill. You can see the septations of the sphenoid sinus and the posterior wall of the sphenoid. In Figure 4, the mucosa of the sinus is removed with a curette. In Figure 5, the septations of the sinus are drilled to the posterior wall, which allows greater visibility of the swell-based structures. We can clearly see the sellar and carotid prominences as well as the pleural recess. The sellar prominence holds the pituitary gland, and the carotid arteries sit laterally in the carotid prominences. In Figure 6, the sellar prominence is fractured and resected to expose the dura. To fully expose the dura over the pituitary gland, the bone lateral to the pituitary is thinned with a drill to be removed with more precision. This sketch shows the surrounding vascular structures that are voided during drilling. The pituitary is surrounded by the anterior and inferior intercavernous sinuses and the right and left internal carotid arteries and cavernous sinuses. This figure shows these critical vascular structures in a sagittal view. You can see the carotid artery that travels through the cavernous sinus, and in blue we can see the intercavernous and cavernous sinuses that surround the pituitary. Once exposed, the dura over the pituitary is cauterized with a bipolar for hemostasis. The dura is incised, and in Figure 9, the dura is resected with a tissue shaver. Cautery around the periphery is used to further shrink the dura. The pituitary gland is incised in Figure 10, and Figure 11 shows the tumor removal using section. Once the tumor tissue is resected, the dissection cavity is then packed with gel foam, seen in Figure 12. The sinus is then covered with a pedicled nasoseptal flap. This flap was created from septal mucosa, and it is connected to blood supply through the sphenopalatine artery and vein. My final illustration is designed for a cover of the Journal of Neurosurgery. I chose to illustrate the thinning of the bone lateral to the sellar prominence while highlighting the important vasculature that must be avoided during this step. The second image shows the tumor removal step and provides a lateral view of the same vasculature. Here's a close-up of the final illustrations, and I welcome your comments or critique.
I love the views that you've chosen. It's very didactic and it shows the anatomy so clearly. This is a really complicated thing to understand, just three-dimensionally, and I think you've captured it really well.
Thanks.
And you used quite a bit of atmosphere to bring us into the focal area of each of those by more detail and light and shadow, gradated color and shadow out in the periphery. Draws our eyes right into both of those.
It was amazing how when you were going through the various steps, when we got to that top image on the black and white, all of a sudden the anatomy kind of came alive to me when we were putting in the arterial components here. It brought it to life, so I'm really glad to see that image. And it's beautiful color. Well done.
There are no further comments. I will welcome my classmate, Colin Ting. Thank you. Hello, everyone.
For my first procedure, I am presenting a medial patellofemoral ligament reconstruction. I will begin by taking you through the procedure I observed with a series of sketches. Here, we are looking at the medial surface of the left knee. Shown in blue is the medial patellofemoral ligament. It originates from the femoral condyle between the adductor tubercle and the medial epicondyle and inserts onto the medial patella. Lateral dislocation of the patella from a traumatic injury often results in tearing of the ligament. Reconstruction of the ligament helps restabilize the knee and prevents future dislocation. For this arthroscopic procedure, A 180 millimeters gracilis tendon allograft was harvested from a cadaver and pre-prepared at one end with the whip stitch technique. Standing medial to the patient's left knee, the surgeon makes 2 incisions. First, skin incision A is made along the medial border of the patella, and dissection is carried through the medial patellar retinaculum to the bone. A small bone chop is made in the medial border of the patella in preparation for drilling, also called reaming, in a later step. Next, skin incision B is made just proximal and posterior to the medial femoral epicondyle, and dissection is carried down to the bone. A subfascial tunnel is then created using blunt dissection, connecting the 2 incision sites. The tunnel is made deep to the medial retinaculum and superficial to the joint capsule. The next step is the creation of a femoral tunnel at the ligament's anatomical insertion. In 5A, a beath pin is reamed across the femur and out through the lateral cortex and skin. A cannulated reamer then reams over the beath pin to a depth of 30 millimeters to accommodate the graft size. The beath pin is left in place after reaming. With femoral tunneling complete, the surgeon prepares the patella for graft fixation. In B, the medial edge of the patella is reamed to a depth of 20 millimeters. The free ends of the suture on the pre-prepared end of the graft are threaded through a push lock anchor, and the anchor is inserted into the patella. In C, the free end of the allograft is then cut to a length that will insert 30 millimeters into the femoral tunnel and whip stitched. The prepared graft is then passed through the subfascial tunnel using forceps and out of the femoral incision. The sutures are threaded through an eyelet in the beath pin, and the pin is pulled out of the lateral femur, guiding the graft into the femoral tunnel. With the graft in the femoral tunnel, the surgeon flexes and extends the patient's knee to achieve proper graft tension. It is important to avoid over-tightening the graft to avoid medial dislocation. While maintaining proper tension, the graft is secured in the femur with an interference screw using a guide pin. The surgeon tracks the patella by testing the knee's full range of motion and performs a layered closure of soft tissues. Here is how I would incorporate the illustrations into a surgical journal. And here's my final illustration of the last step just shown. I now welcome your feedback.
Very, very clear description, taking us through the steps. Thank you for that. Very easy to understand. I think that your style, your tonal style and your line style work together very nicely. They don't look disjointed. I think the weight of your line and how you use some line in your tone work as well work together very nicely. And I think it was a nice decision when to use each.
Thank you.
The inset view really helps me understand the, it's a conceptual view that really helps me understand the relationships in the main figure A. So I think we resolved those spatial relationships well.
Thank you.
Very, very nice drawing and diagram. Here, as you did in your sketch, you could put the initials back in for the joint capsule and the retinaculum. I thought that was a good touch in your sketch. It should carry over into this drawing
Okay.
as well.
I have a comment from Facebook. Oh, Emily Ling mentioned she really likes the rendering, but she would also think that the toning so much of the outside leg obscures the bone form a little bit.
Thank you. Great. If there are no further comments, I'll move to my second procedure. For my second procedure, I'm presenting a robot-assisted right upper lobectomy. I will again walk you through the procedure I observed with a series of sketches. This right upper lobectomy is a minimally invasive thoracoscopic procedure commonly used for the treatment of early-stage lung cancer found within the upper lobe of the right lung. Removal of the upper lobe requires ligation and division of vessels and airways to the lobe, as well as division of incomplete fissures. The patient is placed in the left lateral decubitus position. 5 ports are placed as shown. Port 3 is for the camera, and ports 1 and 4 are for the robotic arms controlled by the surgeon's left and right hands. The surgeon views the lung from its lateral aspect. These first 2 sketches provide a zoomed out view showing the steps leading up to the division of the oblique fissure, which is frequently incomplete. Dividing this fissure first allows the surgeon easier access to upper lobe vessels and airways. In figure 3, the upper lobe is reflected superiorly and the interlobar fissure is dissected, exposing the pulmonary artery where the horizontal and oblique fissures intersect. For the specific case depicted, an aberrant posterior ascending artery was found. Normally, as seen in 4A, the posterior ascending artery, which supplies the right upper lobe, arises from the main trunk of the pulmonary artery. In this patient, as seen in 4B, the artery shared a common trunk with a superior segmental artery, which supplies the lower lobe. The aberrant artery will need to be carefully isolated and divided once better exposed. Next, in figure 5, the lung is reflected anteriorly and the posterior hilum is dissected to expose the bifurcation of the right main bronchus into the right upper lobe bronchus and the bronchus intermedius. In 6 and 7, a vessel loop is then passed through the 2 dissection sites, carefully guided over the right pulmonary and superior segmental arteries and under the aberrant posterior ascending artery. 8 shows a posterior view of the looped fissure with right upper lobe structures safely isolated and ready to be divided. In 9, the oblique fissure is completed with a robotic endostapler. With the fissure divided, the upper lobe can now be retracted further superiorly, opening up the working area. In 10, the aberrant posterior ascending artery is encircled with a vessel loop and divided with an endostapler. Dividing the artery provides access to the right upper lobe bronchus, which is similarly looped and divided in 11. Then, in 12, the truncus anterior artery with its 2 branches are dissected out and divided. This completes the division of all upper lobe arteries and the right upper lobe bronchus. Seen in the top inset, the lung is next reflected posteriorly and the anterior hilum is dissected. In 13, the superior pulmonary vein is isolated from the middle pulmonary vein and divided with the stapler. With all vessels and airways to the upper lobe divided, the incomplete horizontal fissure is stapled, freeing the lobe completely. In 15, the specimen is placed in an endobag and removed through the anterior port site. I fully illustrated step 11, division of the bronchus, to be one slide within a PowerPoint series that shows the sequential division of structures. It provides orienting and schematic images along with the operative view. Thank you, and I now welcome any comments or questions.
the risk of embarrassing you. So we worked together on the first surgery, and you showed your second and your third. Your sketches have just grown exponentially. Your fluidity in your sketching and your ability to observe tissue reaction, really well done. Very nice.
Hi. I know this isn't the main part of the class, but it's certainly an element of it, so I wanted to bring it up that I think your presenting style is really clear. I think this is like the first main time that you guys are all up standing in front of the stage and speaking, and you took your time explaining the steps, you spoke slowly and clearly, and it was easy to follow along, so good job.
Thank you.
I wanted to compliment the lighting on the piece on the right. I mean, it really gives you a sense of drama for the moment that's about to happen. And there's a nice contrast with the simpler line work on the right that really clarifies all the major structures, but then it gives you more of a surgical view on the right. Just really appreciate that.
Thank you. Tim?
I'd like to compliment you on your, in a sense, limited color to what looks like a tone drawing. I think it has a good sensibility about it, and I think there's enough there that brings us into each of the images without overpowering us with color.
Thanks. Juan?
I think the use of the diagrammatic illustrations here, the insights, really clarified for me the anatomy of one of the commenter. The fact that you're doing the two diagrammatic is extremely helpful in terms of understanding where we're at.
Great. That was my goal. Corey?
Was the loop that you're showing, was it actually yellow in the surgery?
It is commonly yellow.
Okay. I just think that you have such limited use of color and you're using kind of conventional color for the vessel. I'm not sure why that has such a noticeable color applied to it.
Do you have an alternative color suggestion?
Tan color, something a little more
Okay.
saturated and vibrant.
Okay.
Because it's really a secondary or tertiary role in your overall picture.
Great.
There's a comment on Facebook. John Dorn mentions that you would like to be really careful with leader line placement. Some end at a branch of anatomy or end a little short, especially one slide back from the final slide.
Before this final. Thank you, John.
Yep.
Ellen, can I make one more comment? Just something to consider, especially on a slide image. Your what is number 10, the truncated artery, sits right in front of the bronchus, and it's probably what you saw, but I think as the illustrator it would be wise to offset those a little bit, because that very important segment kind of gets lost in the object of the background, in this case the bronchus. So I think, to think about kind of a quick read, just maybe taking some liberty to offset it would help clarify and just make your job of teaching the anatomy a little bit easier.
Okay. Thank you. With that, I would like to introduce my classmate, Jamie Peterson. Thank you, Helen. For my first procedure, I illustrated a paraesophageal hernia repair fundoplication. I will take you through a series of 9 sketches that depict the procedure. A paraesophageal, bless you. A paraesophageal hernia is caused by the hiatus of the diaphragm being stretched and allowing the stomach and esophagus to migrate into the chest. The paraesophageal hernia case that I observed had over 50% of the stomach in the thorax. Figure 1A shows the patient in a supine position with port sites for laparoscopic and robotic assisted procedure.
as well as the severity of the hernia. Figure B illustrates the anatomy of the hernia sac. Figure 2 shows the stomach mobilization. After the liver is retracted, a window is created in the greater omentum and is extended toward the short gastrix in the angle of His. The lesser omentum will be opened to allow access to the right cruise. In 3, the hernia is reduced by pulling the stomach and omentum into the abdomen to achieve a 3 to 4 centimeter tension-free intra-abdominal esophagus. In figure 4, the hernia sac is excised using graspers and harmonic scalpel. The goal is to detach adhesions between the hernia sac, mediastinum, esophagus, and stomach. The hernia release will expose the diaphragmatic current on both sides. After the hernia is excised, the Da Vinci robot is deployed. Figure 5 shows the ports of robotic instruments with the surgeon's right and left hands indicated, as well as the reduced hernia in its anatomical position. In 6, a choroplasty is performed. A penrose is placed around the gastroesophageal junction to retract the esophagus to patient left, exposing the crura for closure using 3 pleated interrupted sutures. The goal is to reduce the hiatal opening to allow passage of the esophagus. Figures 7A through 7D depict the toupee fundoplication, creating a cuff of stomach to prevent reoccurrence of herniation to the chest. Note the placement of the 3 sutures in the esophagus, avoiding the vagus nerve. In figure 8, a single stitch fundopexy anchors the fundus to the diaphragm to prevent posterior torsion of the stomach. In figure 9A through D, a gastropexy anchors the stomach to the abdominal wall to further prevent stomach twisting. Using an endostitch, 2 sutures are placed in the body of the stomach and grabbed by a suture passer, pulling them to the exterior abdomen. The sutures are then secured to the abdominal muscle. I chose to illustrate figure 5 as a schematic overview of the robotic setup and figure 6 in full color depicting the robot-assisted posterior choroplasty step. These figures were created for a surgical textbook. This is a close-up of figure 6, the moment of the loading of the final pledget onto the needle to complete the choro closure. And I'll welcome your feedback. David?
Nice palette, nice handling of the tissue. Again, I feel like you did a good job of deciding where to add detail, where to let detail go, so things are clear and very didactic, so I think really well done. The one recommendation I might make would be to maybe move the right instrument out so we can see what's going on or what's just been completed, just to increase the amount that we're covering in this one image. But overall, very nice, very well done.
Thank you. Cece?
Hi. Could I ask, did you use 3D at all in this piece?
I did not.
It looks, my first impression was that you used a little bit of 3D because the relationship with the structures is so well defined. To me, especially the instruments feel so 3-dimensional. So I guess it's just your use of shading and highlighting tonality that pulls it all together. But it looks very nice, really well done.
Thank you. If there are no other comments, I will move on to my next surgery. The second procedure that I'm presenting is a resection of a pediatric cervical intramedullary ependymoma. The case I observed, the patient had an ependymoma located between C1 to C3, seen in pink on figure 1A. The patient is in a prone position to allow access to the spinal cord and tumor. The incision was made from the notch of the foramen magnum to C4. Figure B shows an actual view of the normal spinal cord at C2, while C shows the extent of the ependymoma in the spinal cord, seen in pink. In 2, in preparation for a laminectomy, the paraspinous musculature is stripped off with the spinous process and lamina of each vertebrae. The lamina of the vertebrae are cut bilaterally using a bone scalpel and straight hemostats for stability. C2 and C3 are removed as one unit
followed by C1 to expose the dura of the spinal cord. And 3, the dura mater is incised after being lifted off the spinal cord with a suture. In figure 4, the dura mater is retracted and sutured to the paraspinous muscles. The arachnoid mater is opened to expose the spinal cord using microscissors. In 5, the ependymoma is exposed after the posterior median spinal vein is cauterized over the tumor location. The spinal cord is open along the posterior median sulcus using forceps. The inset shows an axial view of C2 with laminectomy and retracted dura for the tumor exposure along the posterior median sulcus. In figure 6, the extent of the spinal cord exposure and the start of the tumor removal using a curette and section is shown. In 7, the dura is closed after the spinal cord is irrigated and the cotton strips and retracting sutures have been removed. 2 sutures are used to close the dura, starting at the corners of the incision and tied in the middle. In 8, a muscle flap followed by fiber glue are used to patch a CSF leak. Figure 9 shows a laminoplasty of C1 through C3 with surgical plates and screws. C1 is replaced first, followed by C2 and C3 as one unit. Figure 10 shows the muscle, fascia, and skin closed in 3 layers. I chose to illustrate the tumor in the process of being removed with a curette and suction. The inset shows where the tumor is accessed on the posterior median sulcus. The layout shows was a slide presentation. And now welcome your feedback and comments. Jenny?
So this is the first time I've seen this, and I'm really impressed with your sketches because I thought for sure the final was going to be done at Hernia.
Oh.
Your sketches are so clearly done. I do love seeing the color as well. I think it's very well done. But yeah, great job with the initial sketches. Really, really is clear.
Thank you. Corey?
You have a very well-developed personal style that there's similarities in both of your final renderings in Photoshop. They're beautifully done. I think similar to another one, if this is intended for slide, your labels are a little bit small.
Okay.
Sitting back here on some of the structures on the image on the right.
Understandable, thank you. If there are no further comments, I would like to now introduce my classmate, Noelle Burgess. Thank you, Jamie. The first set of sketches that I am presenting you today are for the coronary artery bypass graft procedure. When the arteries that supply blood directly to the heart tissues become narrowed or blocked, a coronary artery bypass is often performed to improve flow to the area. This coronary artery bypass was performed with a greater saphenous vein graft. The vein harvest proceeds endoscopically, beginning with a right medial thigh incision just superior to the knee. In figure 1A, you can see the vein being separated from surrounding tissue. Once the vein has been fully mobilized, proximal and distal attachments are cut and cauterized endoscopically. In figure 1B, you can see that extraction has begun with an endoscopic grasper. In figure 1C, the vein has been gently extracted by hand, although surgical instruments are often used to complete this task. In figure 1D, vein graft preparation and clipping is almost complete. Fluid is pumped into the vein to ensure water tightness and preserve endothelial integrity. Any missed branches are discovered and clipped at this time. Once preparation is complete, the vein is temporarily stored in preservative solution. Next, a midline incision is made in the chest and a sternotomy is completed. In figure 2A, a roll track protractor is placed and the left internal mammary artery, or lima, is harvested in pedicle fashion, preserving surrounding tissue and small vessels. The lima graft harvest proceeds to the level of the artery's superior epigastric branching. Here, as shown in figure 2B, the artery is clamped, divided, and secured out of the way.
With all graft harvests complete, the coronary artery bypass begins in earnest. The thymus is divided along its midline, and the pericardium is incised in a reverse T fashion to gain access to the heart. Next, a pericardial well is created. The patient is then cannulated with systemic and venous flow lines and connected to cardiopulmonary bypass circuit. An aortic cross clamp is applied and the heart is arrested using antegrade cardioplegia. In figure 5, you can see the proximal target of the saphenous vein graft. Here, an anastomosis is made in end-to-side fashion between the proximal end of the saphenous vein graft and the ascending aorta. Next, the heart is flipped superiorly to gain access to the distal target for the saphenous vein graft, the oblique marginal coronary artery. An anastomosis is then made in an end-to-side fashion. The final graft target in this coronary artery bypass procedure is the left anterior descending artery, or LAD. In the main image, you can see an end-to-side anastomosis has been made between the pedicled internal mammary artery and the LAD. In figures 7A through 7D, I have also included the graft tip preparation and suturing technique for an end-to-side anastomosis. In my final image, I chose to emphasize the grafts and their target areas with spot color. The top inset shows the free saphenous vein graft with its proximal anastomosis to the aorta. The bottom inset shows the distal anastomosis of the pedicled internal mammary artery graft to the LAD. I would now like to open the floor for discussion. Jenny?
Just a question, what is the intended format for this?
PowerPoint.
Oh, okay. I think I'd make your inserts a little bit bigger for PowerPoint.
Okay. One.
I really like using the spot color in essence on this area that you're trying to call attention to. I have a little bit of a problem seeing the difference between the pedicle graft that was put in and the rest of the heart tissue. You may want to play around with contrast or some other kind of distinguishing manner to kind of bring that pedicle a little bit more forward. Maybe some shadow on that side might help kind of work that out a little bit.
Lydia?
This is actually related to Lon's comment by coincidence. The line work in the blue area is very clear and crisp. It almost looks like colorized pen paper. And I love that style. And I think if you carried some of the crispness of the line into the red, purely colored area, it would actually fix what Lon is referring to. But maybe just duplicating the red line and darkening it a little bit. Because it's so beautiful in the blue areas.
A comment from Facebook. Laura Swan Roy mentioned she likes the color here, but the blue might be a bit saturated and a little bit distracting. So adjusting the saturation just a little bit to focus attention on the grafts would be great.
Thank you, Laura. Anyone else? All right. Thank you for the excellent feedback. The second set of sketches I'm presenting are for a minimally invasive distal pancreatectomy and splenectomy procedure performed to remove a pancreatic tumor. This procedure was performed robotically. For those of you that are unfamiliar with robotic procedures, I chose to make an illustration showing the operating room setup. In this procedure, small ports are placed in the abdominal cavity. These ports are used to insert instruments and a camera. The surgeon controls surgical instruments robotically from an operative console shown here in the upper left of the screen. The patient cart, my upper left. The patient cart suspends robotic limbs over the patient, and a surgical assistant switches out instruments as needed. Here's an illustration of the relevant anatomy for this procedure. Of particular note is the investment of the splenic artery and vein
in the large pancreatic tumor. For this procedure, the distal pancreas, tumor, and spleen will be removed from the abdomen. This removal will require the division of the splenic artery, splenic vein, and short gastric arteries and veins. The procedure begins with the division of the gastrocolic ligament, separating the stomach from the greater omentum. Division began in the center of the ligament, then worked towards patient left and stopped before the short gastric vessels. Next, division proceeded towards patient right, stopping before reaching the origin of the gastroepiploic artery, where it branches from the gastroduodenal artery. Once the gastrocolic ligament was divided, the stomach was elevated and secured to the anterior abdominal wall, allowing for direct visualization of the pancreas. Next, the inferior border of the pancreatic neck was incised, and this space was carefully dissected free to identify the course of the superior mesenteric vein, or SMV. The pancreatic neck was elevated, and the course of the SMV was followed superiorly until the splenic vein was identified. The splenic vein, as shown in figures 2A through E, was then controlled with silk tie, clipped, and divided. The superior border of the pancreatic neck is then incised, and the celiac trunk is identified where it branches from the abdominal aorta. At this time, the common hepatic artery and splenic artery are visible as they branch from the celiac trunk. The left gastric artery is not visible as it dives behind the stomach. With the superior and inferior border of the pancreatic neck free, it was then looped with a penrose to ensure mobilization from underlying structures was achieved. The penrose was then used to guide the endo-GIA stapling device across the pancreatic neck. At this juncture, the stapler was fired, sealing the end of the pancreas and dividing it simultaneously. With the pancreas divided, the splenic artery is easily accessible. The splenic artery is then test clamped, confirming that blood flows from patient right towards patient left. This ensures that the target artery is in fact the splenic artery and not the common hepatic artery. Next, as shown in 6A, the splenic artery is looped with silk ties, 2 proximal and 1 distal. Then in 6B, clips are applied. And finally, the artery is divided in 6C through D. Mobilization of the pancreas, spleen, and tumor is then commenced. First, the specimen's inferior border is mobilized by taking down the transverse mesocolon. Then, with the cautery and division of the short gastric vessels. And finally, lifting the specimen out of retroperitoneum by incising peritoneal attachments to the abdominal cavity, particularly those between the specimen and the splenic flexure of the colon, and between the spleen and lateral abdominal wall. With the specimen mobilized, the spleen, pancreatic tumor, and pancreas are then bagged and removed from the abdomen through a periumbilical port incision. Here you can see the surgeon gently maneuvering the specimen in a circular motion to work it free of the abdomen. In this case, since the specimen was so large, the incision had to be lengthened by several more centimeters. Finally, the specimen is sent to pathology to get an accurate diagnosis. In this case, the tumor was classified as a pancreatic neuroendocrine tumor, a relatively uncommon neuroendocrine neoplasm originating from pancreatic islet cells. Here's my final color illustration of the moment the splenic artery is looped. I chose to colorize this illustration as it shows all of the key anatomy involved in the procedure. I now open the floor to comments. Tim?
I got to compliment you on all of your sketches. Step by step, you led us on a merry chase to the end. really well done. And what you've done here is kind of keeping the quality of your line and your sketching, and it's got a beautiful look there. Very nice.
Thank you, Tim. Jenny?
This particular, I mean, the final piece is beautiful. There's another slide that you had that had 4 of the kind of key steps that I know they were sketches, but they almost look like finals. They definitely complemented each other. It was a really nice plate.
Thank you. Corey?
I think in all your sketches, your hands are beautifully done, really convincing, especially the foreshortened hands in the cardiac procedure. And I think, once you
great convention to draw my eye into what was the problem here. I miss it in this image because it gave me a sense for turning. It gave me a sense for what was it. Sometimes you were taking off letters for tumor, and you still read it as tumor because it kind of followed that after a while. So I would love to see it.
Okay. I'll take that into consideration, Mom. Thank you. Any other comments? No? In that case, I would like to introduce my classmate, William Guzman Jr.
Thank you, Noel. The first procedure I observed was a laparoscopic right radical nephrectomy. I will now narrate the procedure using a series of pencil sketches. Shown in figure 1A, the patient is placed in a modified right flank position. A Bayer's needle is then inserted into the umbilicus to insufflate the abdomen. Figures 1B and 1C depict the 4 laparoscopic work placements, as shown here. The head is towards the upper right corner of the screen, and the legs are towards the lower left corner of the screen. Figure 2 demonstrates the view of the laparoscopic camera to visualize the right lobe of the liver and right flexure of the large intestine. In figure 3, the liver is retracted and the white line of Tolt is identified and incised to drop the right flexure of the large intestine to expose Gerotis fascia covering the kidney. In figure 4, the inferior pole of the kidney is dissected to reveal the ureter above the psoas muscle. In 5, the kidney is lifted and further dissection is used to identify the right renal vein and right renal artery. In figure 6, the renal artery and renal vein are taken with sequential fires of an endovascular stapler. The adrenal gland is identified and spared by detaching it from its superior attachment to the kidney in figure 7. In figure 8's concept, the ureter is divided with the ligature. Further dissection separates the lateral attachments of Gerotis fascia. The right kidney and Gerotis fascia are placed in a large endocath bag in figure 9. In 10, a midline incision is made below the umbilicus to remove the kidney in figure 11. The port sites and midline incision are then closed to complete the procedure. I chose to illustrate the stapling of the renal vessels shown in figures 6 through 7 in a journal format. Here are the close-ups of the finished figures. I now welcome your feedback.
Nice handling of tissue. One thing I'd say is maybe play with your value a little bit. You've got different cues, but the values are similar. And so from a distance, they tend to blend a little bit. Nice tissue reaction, nice handling of the instruments, and positioning on the page.
I will now proceed to my next procedure. The second procedure I observed was a right total knee replacement. Due to arthritic changes in the knee, the patient opted to undergo a total knee replacement. The implant used was a Smith & Nephew Journey 2 bicruciate system for artificial ligament support. In figure 1, a midline incision is made over the right knee, followed by a medial parapatellar arthrotomy. In the second figure, fat from below the patellar tendon is removed and the patella is everted, as shown here. In 3A, the ACL and BCL are resected, which will later be replaced with the bicruciate system. In figure 3B, the drill is inserted into the femoral canal. In 4A, the alignment guide is inserted into the femoral canal and pinned in place. In 4B, the distal femoral resection is performed to show the results in 4C. In 5A and 5B, a retractor is used to elevate and displace the femur to expose the proximal tibia. In figure 6A, a tibial jig is pinned in place to support the tibial stylus, which measures the meniscal height. In 6B, the proximal tibia is resected to show the results in 6C. In 7A, a femur sizing guide is placed and is used to guide 2 drill holes, shown in 7B. In figure 8A, the femoral cutting block is inserted into the femur to create 5 new planes, shown in 8B, with results in 8C. In 9, the knee gap is assessed using a spacer. In figure 10A, femoral and tibial child components are placed. In 10B, a box preparation jig is inserted into the femur to create the box joint in 10C. The box and articular surface trowels are placed in 10D and 10E. The trowels are then assessed in figure 11. After confirming the trowel sizings, the base plate is punched and then removed in figures 12A through 12C. In 13A, the final tibial implant is inserted, followed by the final femoral implant in 13B. In 13C, an articular surface trowel is inserted and then assessed in figure 14. After confirming the correct sizing again, the final articular surface insert is placed in 15A. The patella is elected to not be resurfaced, the final implants are set in place, and the incision sites are closed. These are the sketches from figures 10A through 10C. I chose to fully render these figures in the next slide. Using the dimensions of the knee implants from the manufacturer and anonymized patient CT data, I was able to sculpt a 3D representation of the procedure using Cinema 4D and ZBrush. In this PowerPoint layout, I chose to model figures 10A through 10C depicting the creation of the femur box. I now welcome any feedback. Jenny.
Your sketches were magnificent. They look complete. They look like they were done. I don't know if you did them in Illustrator, but they're very clean and very easy to follow.
I think that the convention you set up, this is an exception to it, but the A, B, and C, where we would see the jig, we would see the saw, and then we would see the result of that, was a very effective way to take us through these complicated steps and show what was being done in each phase.
Really beautiful modeling. I just wonder, I would love to see this with a colored background so that the highlights on the metal are emerging so much with the background color. It would really pull the form out even more. It's such a beautiful modeling job.
I just want to compliment you on diving into 3D on this, and it's a perfect example of where it's so useful in surgical. I saw some of your femur models, your bone models, and I think you lose a little bit of the definition. I know you want them to be secondary, but they seem to flatten out a bit. And it might be the projection, but I would encourage you maybe to play with the lighting a little bit more, just to get a little bit more of the form, because you did such a nice job on the bone model. And I think it gets lost a little bit from this distance.
I actually like the interplay between the fading out of the bone and the starkness and more sharpness on the implant components. That is the main actor. I find that it's really well done. It doesn't have the feel of a 3D. It almost looks hand-rendered in a sense. I think it's because of the black kind of outline accents here and there. But it's just really elegant.
I have comments from Facebook. So Zipporah Thompson mentions, great job on the detail and clarity of all the guidance equipment for the total knee sketches. And Laura Swan Roy mentions, really nice ghosting solutions in the sketches.
Thank you. Alongside the rendition of the trial implants, I created a short animation to demonstrate the final implants in the knee. to all the surgeons who perform the procedures and work with us to refine our illustrations. A special thanks to all the wonderful operating room staff and nurses who are accommodating us. And thank you to all family and friends for joining us today.
William always has a little something up his sleeve. That was an excellent job. I want to congratulate all of you on completing the surgical illustration course very successfully. I neglected to mention at the beginning that we have remote viewers, so there were a number of people. Daisha, can you tell us how many people were viewing remotely?
15, 20, 25, somewhere in there.
So maybe a couple dozen. That's wonderful. I think most of them were alumni, maybe potential employers of our graduates. I invite everyone to come back to the reception area. There are prints of all the final pieces, including ones that weren't presented, on large boards, and there are some refreshments for everyone to enjoy, and I hope you have an opportunity to speak directly to the illustrators. So please welcome, please join us in the reception. Thank you.